First of all, I'd like to start out by thanking Dr. Liu, and I'm sorry, is it David, for setting up my talk very nicely. In fact, they made the points of my first 2 slides, I believe. We also were interested in what happens in the real world, and we were fortunate enough to have it. In terms of disclosures, it was actually started by some funding, seed funding that we got from both Janssen and Eli Lilly to help build some software. Now, they have not had any input into this into this database or anything since that time, but nonetheless, they were instrumental in getting it started. Sorry. All right, so in terms of things, actually, I was going to talk about the challenges of evidence-based medicine, and you all know that pretty well, but then I will follow it up with talking about something called the Personalized Advantage Index, and then talk about our data set and what it shows us about ECT versus a combination of S-ketamine and ketamine. It's predominantly a ketamine group in terms of antidepressant response, and then in terms of the response of suicidal ideation. We're limited in that we had only the QIDS-SI available to us. We also have something called the BASIS self-harm score, but the primary thing that we looked at was the QIDS-SI. All right, so as you know, evidence-based medicine is choosing treatment based on scientifically proven information on the medical options available to the patient. And as just been said, who is our patient? If you think about it, sorry, I'm having trouble with this clicker. Let me try that one. Got it, thank you. If you think about it, when we talk about treatment-resistant depression, well, are we talking about straightforward unipolar? Are we talking about bipolar depression? Or are we talking about some of the depressive spectrum illnesses we see, complicated by substance abuse and other issues that change the structure of the brain? We also know that age and other demographics affect this. The first episode of depression in a 20-year-old is very different than the first episode of depression in a 60 or 70-year-old. We know that socioeconomic disadvantages are associated with more trauma. We know that trauma causes epigenetic changes that actually can go across generations. We know that family history is important, particularly in bipolars. There's the idea that it's in part of mitochondrial illness. We know that mitochondria are transmitted from mother to child. Type of treatment, I can't do it better than Dr. Liu just did it, so I won't. As ketamine, we've talked about lozenges, we've talked about inhalation, we've talked about intravenous, and there are other ways of, I'm sure, of giving ketamine that I'm simply forgetting about. And then lastly, if you think about what's been done and developed recently about the genetics of just drug metabolism, if you get the gene site testing or any of the other types of testing and you look at it, there's 2 pages of different ways the body handles drugs and gives us a tremendous amount of diversity. So when you're trying to apply the literature to and clinical trials to a particular patient, it's kind of like our brain imaging studies of illness. We can see group differences, but we do not have yet the ability to take a brain scan of an individual person and say you have this problem. So to that end, we came across some work out of the University of Pennsylvania, which was the Personalized Advantage Index. And it was about, what they did was they simply said, can we start with pre-treatment characteristics and develop a statistical way of predicting who's likely to respond. And they compared antidepressant medications to cognitive behavioral therapy and found that they got a relatively small but significant effect in terms of improving treatment selection. So in adapting this to our data set that we had, we wanted to obtain treatment outcome predictions for ECT or ketamine. We wanted to be able to personalize it to an individual patient, and we wanted to be able to explain it. So we didn't want the black box kind of machine learning approaches that one can see with neural networks and other similar approaches. So the candidates we had available to us were a generalized linear model, random forest regression, and gradient boosting decision tree regression. Now, the folks who had done at Pennsylvania had done actually a generalized linear model, and it had worked pretty well for them. We actually chose the next two. And the reason we did that was because in our data set, we have much larger number of variables, 121 to be exact. And it's just too many variables for a generalized linear model to handle well. So we moved to a random forest approach and then also to a gradient boosting decision tree. The random forest approach we used for the depression analysis, and the gradient boosting decision tree we use for the suicidal ideation analysis. So in terms of the antidepressant response, this database, as I mentioned, was started in 2000. It actually has about 7,000 unique individuals in it. But of the people who have good baseline measures and then interim treatment measures and then actually end of treatment measures, it brings us down to 2,526 ECT patients and a total of 235 ketamine patients, of which 43 got ketamine. We had the medical record available to us, and that's the EPIC claims data, and then we also had a clinical medicine inventory that McLean Hospital maintains available to us as well. So we cross-referenced between those two to come up with the data that you saw. And I misspoke earlier, we only had 112 variables. The scales we used were the QIDS 16, the basis 24. Now, Dr. Schatzberg and I are probably the only two people in the room who know what the basis is. It's actually a McLean-grown sort of inventory of psychiatric symptoms. And it covers about 6 subscales. So it looks at depression, it looks at relationships, it looks at self-harm, it looks at psychosis, it looks at substance abuse. And it sort of it has several questions, a total of 24 questions, and then various weightings for that. So we were able to use that, and then we had the Montreal Cognitive Assessment available to us. And so what we did, because we wanted to simulate a clinical trial, and because we were afraid that if we just compared 235 ketamine people to 2,000 ECT patients, that we would skew very heavily these models to the ECT side of the treatment. So we did something called propensity score matching. And in propensity score matching, what we did was we used a logistic regression to try and identify the propensity of, or the probability that, based on your pre-treatment characteristics, what was the probability you were going to get assigned to ECT or you were going to get assigned to ketamine? And then we tried to match. We matched to the ketamine group because it was smaller. And when we did that, we basically got a fairly decent match in terms of QIDS pre-treatment. You can see that they matched exactly. And then things that were different was the ECT group showed a trend towards being a little older. It had more bipolar patients in it. The ketamine group had many more inpatients, and the ketamine group had more medications in the 60 days prior to undergoing treatment with ketamine. And then what we did then was to apply, once we had the groups, we applied the personalized advantage index approach. And under that, what you do is you develop a model. In this case, with the depression, we used random forest. And we used N-1 patients. So of the 470 available to us, we used 469. And based on pre-treatment characteristics, not the post-treatment stuff, you predict the end treatment QIDS. And then, depending upon which of those is lower, you say that treatment that has the predicted lowest QIDS has got optimal treatment. That's the optimal treatment for that person. And then the difference between them is the personalized advantage index. And then you go back to what the person actually got. And you dichotomize and break them down into those who got optimal treatment and those who got non-optimal treatment. When you do that, what you see is that the optimal group does slightly better than the non-optimal group. Now, there's probably several reasons for this, but most likely it's been the non-inferiority kind of discussion that we've been having. And you can also see that the personalized advantage indexes are not very big. So there's not a lot of difference between these two treatments, but but the machine is able to tell us which one is optimal and which one isn't. And when you look, the biggest feature that's important is baseline QID score, so how sick they were. Next comes the self-harm score. Relationships matter. Age, of course, matters. Emotional ability matters, and the MoCA. And altogether, you can see these are the top 10 factors and predictors of outcome. And I don't think anybody as a clinician is surprised by any of these. So to take you through the model for an individual patient, we start out with the model's intercept, or in other words, the score that it predicts for the whole model. And you get an NQIDS of 10 points, an NQIDS of 10.78. Their MoCA score of 28 adds 2.262 to that N score. Their age of 64 takes away 0.2. The basis relationship score takes away 6.16, and you get the idea, so that you wind up for this person predict a score of 11.049 for the prediction. So what's interesting there is, again, that we had a slight improvement. What you will also see is the machine predicted that ketamine was optimal for about 70% of the patients that were in this analysis. And ECT was optimal for 30%. In the upcoming suicide analysis, it's actually flipped. So again, I should mention also that the propensity score matching was done slightly different for these two different analyses based on what we felt would be important. And in this one, whereas the previous one included the baseline QIDS and it included age and psychosis score and inpatient status, this one simply included the baseline QIDS and the suicidal, the baseline QIDS SI item. And still, you can see that the matching here is also, again, pretty good in basis QIDS. You can see there are more women in the ketamine group. There are, again, more inpatients. There are more bipolars in the ECT group, and the ketamine group has more anxiety. As I mentioned, ECT was predicted to be optimal for 3/4. Again, though, note that and keep in mind, this is scaled to, whereas the QIDS total score was scaled up around in the 20s, this is scaled to a max of 3. So there's much fewer degrees of freedom to this data than there are with the QIDS total. But nonetheless, when you do optimal versus non-optimal treatment, and the optimal is in red, you see that it starts out slightly higher and it drops down lower. When we thresholded to an advantage index of 0.75, so we want to see sort of a bigger effect, we still get the same kind of a message in that here the optimal treatment starts out just slightly lower, but actually winds up in a lower place. And these differences are statistically significant. I was curious in trying to understand this a little better and broke it out by ECT patients and ketamine patients. And what's kind of striking is that even the non-optimal ketamine patients do better than optimal ketamine patients. And likewise with ECT, however, this situation, higher suicidal ideation is thought to be optimally treated by ECT. So again, it's a little bit confusing in terms of what this exactly means, and I'm surprised that the machine did this this way, but nonetheless, that is what the machine found. Again, the same kind of features that you see, the QIDS score, the self-harm score, meds. This is broken out a little bit more by which types of meds they got. And then the MoCA comes in and age plays in terms of predictors in the model and factors that the model found important. The other thing that I think is worth noting is, and this is by way of example, I don't want you to get all of the sort of things, but what's interesting is that depending upon which patient we're talking about, the model thoughts of death or suicide can be either contributing or they can be subtracting from the score, the ultimate score that the model is going to give. And likewise, if you look at, and they also vary in terms of importance for each patient, and that's sort of really the personalized nature of this model and this approach. So, in conclusion, routine clinical practice of ECT and esketamine appear to have comparable antidepressant efficacy on average. The PAI model says seems to suggest that based just on pretreatment variables, that we can do better than we're doing in our clinical practice at the moment. But it's a suggestion. And likewise, the anti-suicide effects of these treatments, again, it's a suggestion that we can do a little better in terms of deciding who gets what. But clearly, validation in larger samples with an expanded rating scale montage is indicated. And more importantly, how do you transition this to the clinic? Do you sort of use a lockdown model, or do you kind of take what some people are doing with the learning healthcare network models, where you sort of repeatedly have these iterations of the model and it continues to learn? And then what's the threshold for the clinician acceptance and bringing this into the model? Thank you very much.
Well, thanks very much. Really interesting talk. I'm afraid I've let the time slip a bit, so we probably don't have time for questions, but people could ask Michael afterwards.